Assalamu alaikum. My name is Ahmed Mohammed. Today me and my colleagues will talking about the diverticular disease. This seminar is supervised by Dr.Zahraa. In the beginning we are talking about the definition of diverticular disease. Then we are talking about the causes, diagnosis, signs and symptoms, treatment, and lastly we are talking about the prevention. So what's the definition of diverticular disease? Diverticulum defined as blind pouch leading off alimentary tract. This pouch lined by mucosa that communicate with the gut lumen. The congenital diverticulum have all three layers of the bowel wall affected. In contrast, acquired diverticulum defined as lack or have attenuated muscularis propria due to focal weakness in the wall and increased intraluminal pressure. It's important to know the terminology. So, diverticulum is one outpouching. Diverticula is a plural, multiple outpouching. Diverticulosis is diverticular with no symptoms. Now, diverticulosis is essentially the presence of a lot of diverticula, and this is usually asymptomatic. However, in diverticular disease, there is usually symptoms. One of cause of this symptom is diverticulitis, which is the inflammation of diverticulum or diverticula, and this inflammation causes pain and some bowel problems. There are two types of diverticulum, true type and false type. So what's the difference between the true and false type of diverticulum? When you have a true type of diverticulum, that means all the layers of the colon are involved in the outpouching, and this is what we see in the infants. This is the congenital problem. However, in the false diverticula, it's only mucosa and submucosa that's involved in the outpouching. The muscle layer remain the same, and this is what we see in the adult population. Now we are talking about the epidemiology. Diverticular disease is common in United States, Britain, Australia, Canada, and it's uncommon in Asia and Africa. Affected 5 to 10% of population older than 45 years and 80% of those older than 85 years. Approximately 20% of patients of diverticular disease have an episode of symptomatic diverticulitis. Male is a predominance in patients younger than 50 years of age, with equal gender distribution after age 60 years. Now the pathogenesis and causes. Chronic diverticula tend to develop under condition of elevated intraluminal pressure in the sigmoid colon. This is facilitated by unique structure of the clonic muscularis propria, where nerves, arteria vasa recta, and their connective tissue sheath penetrate the inner circular muscle coat to create discontinuities in the muscle wall. It's not known exactly why some people get diverticular disease, but it seems to be linked to age, diet and lifestyle, and genetics. In this picture we can see the healthy colon. This is the mucosa and this is the submucosa. And this is clonic diverticulosis. Clonic diverticula form when mucosa and submucosa herniated through the envelope that surrounded the intramural vasa recta. Also we can see diverticular hemorrhage, which is the complicated of clonic diverticulosis due to ruptured artery. And another important complicated of chronic diverticulosis is acute diverticulitis, which is inflammation of diverticulum. Now the morphological base for the development of chronic diverticula. Diverticula of the colon are pseudodiverticula, defined by multiple outpouching of the mucosal and submucosal layer, penetrating through weak spot of the muscle coat along intramural blood vessel. A complete prolapse consists of diverticular opening, a narrow neck, and the thin diverticular dome underneath the serosal covering. The susceptibility of diverticula to inflammation is explained by local ischemia, translocation of pathogens due to retained stool, and microperforation. In this picture we can see the chronic diverticulum has a central lumen with surrounding mucosa, where the wall, lacking muscularis, is attenuated. The narrow neck of the diverticulum may become eroded. Now we are talking about cross description. The cross-section of sigmoid colon suffer from diverticulum disease showing: number 1. Multiple small flask-like invagination present along prominent teniculi, filled with mucin or stool but easily empty, may bulge into cirrhosis. In this picture we can see the surface of the colon is hyperemic because of inflammation as a result of diverticulitis. The erosion of mucosa by the stool in diverticular can produce inflammation and hemorrhage. Number 2. Thick and corrugated circular muscle with a prominent accordion-like mucosal fold. In several cases, bowel is segmented and shortened. Several diverticula are seen in this picture along the length of the descending colon. Focal weakness in the bowel wall and increased luminal pressure contribute to the formation of diverticula. Now the microscopical description. No muscle layer around diverticula except for residual bundles of muscularis mucosa. Inflammation due to obstruction or perforation may dissect into adjacent pericolic fat, causing fibrotic thickening resembling colon carcinoma. May have Paneth cell and the intramucosal ganglion cell are common. Mucosal change in diverticula in uncomplicated diverticulosis include increased lymphoid infiltrate, lymphoglandular complex, mucin depletion, mild cryptitis, architectural distortion, Paneth cell metaplasia, and ulceration. Finally, in this picture we can see the diverticulum. Mucosa and submucosa invaginate into the muscularis propria. Now my colleague Sedra Mohammed will continue.
Hi, my name is Sedra and I will talk about the diagnosis. How is the diagnosis of diverticular disease? Because most people don't have symptoms, diverticulosis is often found incidentally during evaluation for another condition by sigmoidoscopy, colonoscopy, barium enema, CT scan, or X-ray, as we see in these pictures. If you are experiencing the symptoms of diverticulitis, it's important to see your doctor. The doctor will ask about: number 1, history, such as bowel habits, symptoms, diet, and other medication, and perform physical examination, possibly including digital rectal exam. 2. Laboratory tests include white blood cell count may show leukocytosis. Blood culture should be obtained prior to administration of empiric parenteral antimicrobial therapy for severe complicated cases. If amylase is elevated, suggested of possible peritonitis or perforation. A pregnancy test must be performed in any female of childbearing age with abdominal pain. 3. Plain abdominal radiography, typically normal in male diverticulitis, but it is stating in severe cases there may be an ileus pattern, obstruction is present, proximal bowel dilation, a large abscess may association with free air under the diaphragm may be seen on upright film in setting of intraperitoneal perforation. 4. CT scanning of the abdomen. 5. X-ray. 6. In people with rapid, heavy rectal bleeding, the doctor may perform a procedure called angiography to locate the source of the bleed. Finally, there is some note about the diagnosis. A contrast enema shows diverticula, but not diverticular inflammation. Moreover, contrast studies may cause perforation. A colonoscopy is relatively contraindicated in patients in whom acute diverticulitis is suspected due to an increased risk of colonic perforation. Now, my colleague will continue.
Welcome all of you. I am Ahmed Ammar. Now we have clinical features. Most patients with diverticulosis have no symptoms or complications, while the patient with diverticulitis experience from the following symptoms. First, abdominal cramp. Second, fever. Third, bleeding from the rectum. Fourth, nausea and vomiting. Fifth, constipation and or diarrhea. There are a potential complication of diverticulitis if left untreated, which are: first, perforation. Perforation is a tiny tears in the bowel wall. These tears can weaken the colonic wall, and if they grow larger, can spill bowel contents into abdominal cavity. This a macroscopical picture show perforation, which are indicated by a row, with gray yellowish membrane on the serosa, while this microscopical picture show a perforated diverticulum with pericolonic abscess. Second, abscess and phlegmon. The abscess form when a diverticula in the bowel becomes infected and fills with pus, while the phlegmon is the infected and inflamed area near the abscess. Both form along the wall of the colon as a result of diverticulitis. This slide shows a diverticulitis with acute inflammation extending into subserosal adipose tissue, which associated with the presence of pus. Bowel obstruction. Bowel obstruction is a blockage in the colon, which can be partial or complete blockage of the large intestine. It's caused by scarring or inflammation, which making the colon too narrow for passage of stool, and this narrowing process known as stricture formation. As we can see in this picture, there is an enlargement of the colon due to accumulation of the stool. This enlargement of the colon can cause a pressure on blood supply of large intestine, which can in turn cause a gangrene. As we can see in this picture, the black color indicated to presence of gangrene. Under microscope, the mucosal surface of the bowel show necrosis with hyperemia extending from mucosa to submucosal and vessels of muscular wall. Fourth, rectal bleeding. Rectal bleeding isn't common, but can occur in patients with chronic diverticulitis. Rectal bleeding is occur when a diverticula damage the blood vessels in the colonic wall, which in turn resulting in bleeding. This picture was taken by colonoscopy that represent the blood drainage on colonic wall because rupture of blood vessels. Fifth, fistula. A fistula is formation of an abnormal pathway between two organs. In diverticulitis, a fistula typically connects the colon with either bladder, small intestine, or to the vagina. In this scheme, we can show colovesical fistula, or the abnormal connection between bladder and large intestine. And this microscopical picture show coloenteric fistula, or the connect between large and the small intestine. On the left side, we can see the small intestine, and on right side, we can see the large intestine. Now my colleague Sama will continue.
Hi, I am Sama. Now I talk about treatment and control. The treatment of a diverticular disease depends on the case if it's complicated or not. Uncomplicated diverticulitis require antibiotics to treat infection and liquid diet for a few days while your bowel heals. Complicated diverticulitis require intravenous antibiotics, insertion of a tube to drain an abdominal abscess if one has formed, and if there is a complication such fistula or obstruction or perforation into the bowel wall, surgery must have to do. Prevention. To help prevent of a diverticular disease, first you have to exercise regularly. Exercise prompts normal bowel function and reduces the pressure inside your colon. Try to exercise at least 30 minutes on most days. Eat more fiber. A high fiber diet decreases the risk of a diverticulitis. Fiber-rich foods such as fresh fruits and vegetables and whole grains soften waste material and help it pass more quickly through your colon. Eating seeds and nuts isn't associated with developing diverticulitis. Drink plenty of fluids. Fiber works by absorbing water and increase the soft, bulky waste in your colon. But if you don't drink enough liquid to replace what's absorbed, fiber can be constipating. Avoid smoking. Smoking is associated with an increased risk of a diverticular disease. Thank you for listening, and a special thanks for our supervisor, Dr. Zahraa.